All right, good morning, everybody. Thank you so much for coming out today to hear our talk on safety and security for people living with dementia. Today's presentation is going to be given by Betsy Posby. She is our nurse clinician. She received her bachelor's degree from the University of Michigan and her doctorate from Rush. Before she joined our ADRC center, she worked with Rush's ADRC center. So she has a lot of experience working with this population. So I'd like to give a big hand for Betsy as she comes up to give our presentation. And then slide-wise, just put the arrow. Okay. All right, so yes, my name is Betsy, and I started out my nursing career pretty much in research. While I was in school to become a nurse practitioner, I was working with Rush and their research center there with dementia research. And then I took different clinical jobs. So once I became a nurse practitioner, I started with palliative care in the home. So seeing patients, very sick patients, trying to manage symptoms all in the home. Beyond that, I worked at a continuing care retirement community, helping the whole community from independent living, memory care, assisted living, the whole spread. So I've seen, the progression of people living independently, safety issues with that, when they need to progress to, more assisted living because of certain things, and then helping families decide when to make that transition. And then also I've done home care visits in the home, primarily working with dementia with behaviors. So dementia patients who safety issues or aggression or combativeness or whatnot to either help facilities or family ideas in terms of managing these behaviors and trying to keep people home. So that's where I've been in a clinical setting. And then when I moved from Chicago to Michigan, I got back in touch with research. So I started in research, now I'm back in research, and in between I've done a lot of dementia clinical work as well. So that's where I've seen it kind of from both sides. And this presentation is going to be on safety concerns and things that I've seen while I've been in the home, in lots of different homes throughout my career thus far. Is there a button too, or just keep hitting that? I don't know if it's, I can do it that way too. I just don't know if it's easier with the button. So just as an overview, as I'm sure most of you do kind of have an idea of this, but a lot of times we talk about the types and stages of dementia. So here we're going to use dementia as the umbrella term, and lots of different types of these dementias, Alzheimer's being the most common type of dementia, vascular, Lewy body, frontotemporal, and then this more like a rare Huntington's, and then a mixed dementia. So it's relevant in a sense that some types of different dementias have different symptoms, different progression and whatnot, but they can all the different types of dementias may have different security and safety issues at different times throughout the course of the disease. So when talking about these stages of dementia, the early, middle, and late, like we said, there's different types of dementias, and the different types of dementias, and also even sometimes the same types of dementias, they're going to progress at different rates based on the individual, based on the disease, based on what area of the brain is being affected. So here, in the early stages, largely independent, needing some assistance with daily activities because memory, problem solving, language skills are changing, but primarily independent, able to be left alone for the most part, can do many activities, participate in many things. Progressing more to the middle stages as the memory and thinking declines, requiring more assistance with basic basic tasks. So when we talk about like activities of daily living, the bathing, the grooming, the dressing. So in that middle stage, really, that's when that caregiver is really coming in for safety purposes, more assistance, because those basic tasks become more difficult for the person with dementia to complete on their own. And also in the middle stages, and when we're going to start having some more behavioral changes. So a depression, anxiety, irritability, aggression, those sort of. So you're having more of a physical change and the behavioral changes in that middle stage. And then late in the stage, as the disease really advances, much more extensive assistance with these basic activities. So unable to get dressed on their own, unable to bathe on their own. The bathroom issues become more of a problem where they're just going to be some incontinence, not being able to control those activities. The communication, the word choices and the understanding language, that becomes much more difficult. And then even we're getting down to the basics, walking and swallowing, just being able to chew, all those sort of basic things. So it's certainly this progression, and there's no, set timeline based on, like I said, the individual, other chronic diseases, the overall health of the individual, the type of dementia that they have. So it's really hard, even the most learned neurologist, if you say, well, how long is it going to take from this stage to this stage? We kind of have a basic idea, but it's really hard to say when it's going to progress. So that's what, when we consider safety concerns with dementia, it's kind of like we can start mentally thinking, okay, we know that these diseases progress. We know that's going to happen, but we don't know when. So a lot of these safety concerns, it's about preventative rather than reacting. So knowing that these things are going to happen at some point, what are some things we can set up ahead of time before they happen, rather than have, the fall or the wandering in the middle of winter? What are things we could do to kind of set up a safe environment to prevent some of these issues from happening? So dementia causes multiple changes in the brain that can impact safety depending on the stage of the disease. These are just very basic examples, but when we're talking about kind of different areas and different domains that that can be affected. So overall judgment, cooking something too long in the microwave, not knowing that, like thinking about a minute versus 10 minutes, pressing the button, walking away, and all of a sudden the microwave's on fire, putting tin foil, silverware, that kind of stuff in the microwave. Those are things where that judgment is no longer intact. So making some poor choices in that way. Orientation, getting lost in familiar locations, sometimes taking a loved one outside of their safe area, their home where they know, going to park, going to a crowded place, that can become very disoriented. And even though you would think, okay, well, they walked with me here, they know where they are, they've seen it, they know where I am, that sort of thing. Because of the orientation difficulties, that can become a safety concern for losing somebody. The behaviors, and we'll talk more about that later, the increased anxiety, agitation, physical behavior. So then we're not only thinking about safety with the participant, but also safety with the caregiver for a combative type behavior. And then motor changes. So that's another change that can happen as a dementia progresses, where balance is affected, muscles become weaker, increasing risk for falls. And then overall senses. So, we rely on our hearing and our vision and our touch, all those things to kind of navigate around in the world. Well, as hearing declines and as vision changes and that sensitivity even to touch, so hot and cold and whatnot, that can actually become a safety concern as well. So when you're considering home safety, that's what I'm going to talk about for a while now. So this kind of child-proofing mentality, kind of have to just go and look in your home like you would, like if you had a toddler living in your home. Not that the person with dementia should be treated as a toddler, But some of those, like we said, that decision-making process or this executive functioning where, you know, they are putting the wrong thing into an outlet, you know, something that shouldn't go into the outlet, sort of things like that. Of course, keeping all firearms in a secure, locked place, things like knives or other dangerous objects, keeping out of reach, out of sight, locked up if needed. You know, the kitchen has a lot of dangerous objects in there that to somebody with full cognition, they're not, you know, it's not an issue, but for somebody with dementia who can be easily confused with what they're supposed to do or how they're supposed to use it, that can certainly become a safety concern. Putting on outlet covers. Some people will actually take the knobs right off the stove, so there's no temptation to turn on the stove and leave it on, especially if they're leaving, if someone's going to be home alone for an hour or two or whatnot, just removing the temptation totally. And then these sort of chemicals, toxic cleaning supplies, etc., being able to kind of put those away. I'm going to see if this will work here. Whoops. Is this going to be audio or not? If I can't do it, it's okay. Oh, that's good. These are just kind of little, these are short little videos that
I'm sorry. Dementia can affect judgment, behavior, physical ability, and personal senses. All of these factors can contribute to safety. Home modifications are needed to keep them safe. As dementia progresses, a person's ability to judge diminish, making it a potentially dangerous place. Here are some tips to help keep your loved ones safe in the home. Use child safety locks for radiation, such as razors and knives in a safe location. Lock away weapons or remove them. Throw away expired food and keep food that you do not want your loved one to access out of reach. Have the phone number to the poison control easily visible. Remove or cover knobs on stoves and ovens. Install a remote on-off switch or turn the gas off if necessary. Signs with step-by-step instructions can be used to remind your loved one of how to use small appliances. Unplug or remove small appliances from sites if they're too dangerous to use. It takes effort and greater your own teaching. Instead, safety modifications to keep your loved one safe at home.
Probably gonna start another one.
I have considered myself as a dementia expert. Now, what is an expert? An expert is someone who knows what they don't know.
Now what do they?
Sometimes what they don't know.
I think not. Oh,
Is that wrong?
yeah. Well, I have one more, but we'll see what happens. Let me get to that one. So this is, I tell people also, especially in the home, when they're trying to take care of their loved one as the dementia progression, it's like, well, I don't want to take away their independence, or I don't want to offend them by not, allowing them to take care of themselves and whatnot. And that's why I say it's not about taking away their independence. It's about simplifying the home environment to make them more independent. So like, he's hungry, allowing him to go in and do that his own way, but also making the choices simplified and easier to access. So that way it improves the safety and also allows the person with dementia to feel independent and that they can make those choices for themselves. So the other big safety concern for many people as dementia progresses, especially for patients in a home rather than like, even an independent living facility or some sort of facility when there's other staff around. But it's very difficult to be with, for one caregiver to be with that person at all times, 24 hours a day. So wandering certainly does happen a lot. And there's some tips to sort of prevent any sort of dangerous situation. Notifying neighbors, local police departments. I tell people you can share a picture with the local police department if that person's ever seen wandering, or even, if they approach other people. And, sometimes people have called the police on people with dementia because they say things they shouldn't say, or they become irritable and act sort of, aggressive and whatnot. It's like, rather than taking this person with dementia to jail, notifying like that local police department, this is something, and then if something does come up or if somebody does call the police, they know them, they know who to contact, and that can be solved fairly quickly. Always having some sort of identification bracelet. The Alzheimer's Association website has ones you can actually buy. It's engraved, it looks nice. Sometimes loved ones will give it to their dementia loved one for a birthday or something special, and on it is engraved their name, a phone number, their address, that sort of thing. Because not everybody is going to take a wallet with them or a purse with them if they exit. At night, alarms on a door, even during the day, alarms on doors. So that little like ding, if you're opening, closing the door. Some people will just put a bell on the door or something like that. putting a high up lock, so like a slider lock on a regular door that you can get to that way. Baby monitors, motion detectors, mats by the bed at night. That way the caregiver's getting some sleep. Also, if somebody tries to get out of their bed at night, you know, there's some sort of notification. Childproof doorknob covers, those things that you have to push in to open the door. That can, you know, that's somebody who doesn't have, you know, cognitive deficits can open just fine, but somebody who with the motor issues and, you know, they may not be able to open it as easily. Putting away coats, gloves, hat, anything that would make, you know, the brain kind of go to, I need to leave. So that can also be kind of like a diversion tactic. And do not leave somebody in the car with the keys. Like sometimes, you know, you leave the keys, especially when we have those little fobs, you just kind of leave the key on there and to go run an errand or something. You know, somebody with dementia may think, okay, hey, they may forget why they're in there, what they're waiting for or whatnot, and be like, hey, I gotta get somewhere else. And then all of a sudden, you know, they're gone in the car. And like we kind of talked about earlier, outings to busy, crowded places, becoming a little agitated and disoriented in a setting like that. And that's really on a case-by-case situation. I would say more in that early stage dementia. Okay, they are doing fine. It's good to get out and socialize. Kind of have to see how your loved one progresses in situations like that. And you may need, you know, start out, you know, restaurants, grocery stores, whatnot, it's going fine. But if that becomes a source of distress, and, you know, you might need to kind of scale down the outings to like smaller groups. And like I said, people will say, well, they've never done it before. People will say to me, if I'm going through some of these elopement things, well, my loved one's never done that before. I don't think they've ever do that. Well, that may be true. Not everybody does that. But like, you know, this is all kind of about prevention. So knowing that this might happen, it could happen out of the blue one day when it's never happened before. So just at least having some sort of game plan in action. I don't need to do that second one. I don't know where it will go, so. Another big safety thing, not just in dementia, but in, well, healthcare in general. I can know back in nursing school how many different lessons and how many different projects that we did that were revolved around fall prevention. But it can be a huge thing. A lot of falls can be preventable, or at least decrease the risk. So really looking at the home, simplifying the layout. Some people with dementia, their visual spatial skills can become impaired. So how they perceive, you know, I can see this here, I can walk around it. Even, you know, like not being able to do that, bumping into it, you know, sit and things like that, that can increase those fall risks. Rugs become a major tripping hazard, slippery rugs. Changes in elevation. So some homes are laid out where there's small steps here and there, and the color of the elevated area is the same color as maybe one step down. So you can get like painter's tape, that bright green or the bright blue, and line the step with that. It comes up easily, it doesn't ruin the floor, but it's that visual kind of cue that, oh, there's a step there. Gated stairways, removing clutter on the ground. Sometimes small animals can become an issue, a cat or a small dog or whatnot that's running under the feet. Shoes or slippers with good traction, that's a big thing, especially senses on the bottom of the feet if they can't feel the ground as much. Sometimes even a neuropathy can affect that. You know, getting something with some good traction. And then the walk-in shower, grab bars and shower next to toilet, you know, basic things like that. Another thing, medication, that especially, you know, as in a geriatric population, the number of medications increase, the times of day that people have to take these medications increase, and that certainly, it can become a safety concern if people aren't taking their medications that they need to take. It can become a safety concern if people are taking too much of the medication they're supposed to take. So as a care, you know, getting that pill box and organizer, setting it up for the week, being able to monitor which days are being taken, when it's being taken, so things aren't getting messed up, and then keeping the medication bottles locked up or out of reach. You may only be able to fill up one day at a time. You know, sometimes people with dementia, they don't know what day it is. So they start out being able to, once their pill box is set up, being able to manage it. But as the disease progresses, all of a sudden they're taking 2 days at a time or whatnot. So that's just one of those things that kind of has to evolve as the disease evolves. Taking a full list of all medications and supplements to every doctor's appointment. You know, there are, as you add different conditions to somebody's medical history, start going to different specialists, making sure that everybody involved in the care knows all the medications that they're on, so we're not having any crossover side effects or interactions. And then another issue that becomes big with dementia is medication refusals. So whether they're paranoid that the medication is, you know, going to poison them, or they just don't want to take it in general. You know, I've seen it work a lot where you just, okay, we're going to walk away, try again in a half hour. They're in a different mood, they take it fine. Prioritizing medication. So as the medication list increases, discuss with the doctor, which ones of these at this point in their health care are the most necessary. So start with those. Can we get rid of maybe some of those multivitamins are huge. Like, is that, you know, a priority at this point? Okay, you know, so talk with the doctor, see if there's anything that can be cut, and then prioritize the ones that are really important to keep them healthy on a day-to-day. And then some medications can be crushed, mixed with food, put in coffee or whatnot. Some cannot. So that's why I always discuss with a doctor before you just go through. I mean, you can read the instructions on the medication as well. It will say whether or not it can be crushed. And then there are some medications that can be switched to a liquid form. So if it's important medication and they're really having trouble with it, say, hey, is there an alternative way that I can make sure my loved one is getting this medication where they don't actually have to swallow it? And then this pocketing pills. So they take it, they drink a glass of water, and you think, okay, it's done. I know they're keeping it like in the size of their mouth here, and then you'll find it, then they'll spit it out later and throw it away. So that's just another thing to be aware of that does happen. Another thing, diet and hydration can certainly become a safety concern, whether it be for their own nutritional intake, not getting enough food, not getting enough water, but you know, increasing risk for falls, infection, delayed healing. Poor nutrition in general can cause, you know, if like there's a wound or whatnot, wound might not heal, wound becomes infected. Not getting enough water, you're going to increase risk for urinary tract infection, which is common in older adults. And then also not getting enough food and hydration can cause dizziness, lightheadedness, falls, that sort of thing. So it certainly is normal for an appetite to decline in somebody with dementia for many reasons. One, they're just not as active, they're not burning as many calories. The body, as any disease progresses, the calorie intake is not needed as it once was, and people just aren't getting as hungry. So that's normal. So as you see a decline in appetite, then that's also about trying to be intentional about what they are consuming. So avoiding empty calories, really like sugary drinks that might fill them up but aren't providing any sort of nutrition. So thinking about what can be the biggest bang for the buck in terms of a bite. And let's see, then also people needing assistance, cutting up food, feeding themselves, swallowing. If you're noticing, well, I mean, first start with cutting up smaller bites, you know, as swallowing becomes more difficult. Some people start actually having difficulty with liquids, thin liquids or whatnot. So liquids need to be thickened, or food needs to be more of like a pureed consistency and that sort of thing. And that doesn't all happen overnight. So that's sort of kind of altering the food and how people eat. That's kind of a gradual progression that continue, but certainly bringing it up with the doctor. If you notice some choking while they're eating, you know, that's something that you can either get a speech therapist to come and evaluate the swallowing and then make their professional recommendations on what they feel like is safe, or, you know, ask the doctor what, you know, for like a swallow evaluation or things like that. But the danger for swallowing, obviously choking, but then this aspiration pneumonia. So it's a food or liquid gets into the lungs rather than the digestive tract and can sometimes turn into an aspiration pneumonia. A lot of people with advanced dementia, that ends up being like a bad infection that sends them to the hospital, or even can be something that eventually they die of an aspiration pneumonia because the body's immune system is just so down, and then they end up with that. So driving, it always comes up, always. And I have felt like I've gotten in the middle of so many driving conversations in the clinical side and also like in the research side when they're like, well, tell them that they're not supposed to be driving. It's like, okay, well, I guess if you want me to do it, I'll say it. We can sometimes see on our testing when people come in for our research studies and do the neuropsych testing, score very poorly in visual spatial, very poorly in executive functioning. Well, those are important things that you need to drive. Your visual spatial abilities need to be intact, and your problem solving, decision making skills need to be intact. So like I tell people, it's not like if everybody did exactly what they were supposed to do on the road, I'm sure you'd be fine. But people aren't doing exactly what they're supposed to do. You need to make split-second decisions. You need to be able to multitask and perceive many things going on at once. As dementia progresses, that becomes more and more difficult. Driving becomes more and more difficult. So some signs that your loved one should consider giving up driving: getting lost in the familiar location. So that short-term memory, the orientation, those skills becoming, and declining. Failing to observe traffic signs and signals. So that's a part of multitasking multiple things, seeing multiple things and then reacting, blowing through a stop sign, stoplight, whatnot. Forgetting to use, turn indicators or whatnot. And then that decreased reaction time. So they're making the right choice, but you can see it's getting longer for them. That response to, another car coming over, or that they need to change lanes or whatnot, that kind of stuff is becoming delayed. And I've also seen, so parking, you have your parking spot, somebody's pulling in, sideswiping the car next to them, visual spatial. So that, the only thing that happened there is they scraped the car. But in the bigger picture, they're having more difficulty perceiving their surroundings. Driving at inappropriate speed can be too slow or too fast. Increased anger or confusion while driving. Typically that irritability is because the task of driving requires a lot from the brain, and it's causing this irritability because it's a confusing thing for them. It's too much. And well, yeah, I said, so the difficulty parking too. I have seen it many times with my own eyes. And I go to I have in my past, a lot of like independent living, assisted living type facilities. And I would park my car far away because I just, try to avoid that. So you identify your loved one. Okay, it's probably not safe for them to drive anymore. I always tell, and I tell our participants and our informants as well in the studies, okay, they're driving right now, they have like a mild cognitive impairment diagnosis, driving doesn't seem affected yet, fine. Drive with them periodically, once a week, once a month, at whatever. So you can be the passenger and assess how they're doing. Even if you're telling me all they do is every week they go to the same coffee shop and have coffee with their friends. That's all the driving that they do. Fine, maybe once a month, go on the drive with them to see how they actually are doing, because this isn't going to be a disease that stays like this forever. It's going to decline. So periodically kind of doing that kind of self-assessment. So then some people, they will take the keys away from themselves. They'll have a close call. They'll be driving and they'll feel nervous and they'll say, nope, no more, I'm done. We got to figure out an alternative situation to get me where I need to get to. Other people, not so much. Taking away the keys becomes a huge loss of independence, a very sad thing for someone when they have to give those keys away. That acknowledgement that this is real, and now they're stuck. They can no longer do and have, control over their own life. So that may, in a situation like that, you may need to involve other people. Sometimes a physician will write a letter or put it on the prescription pad. Works for some people, doesn't for others. You want to try to avoid a situation where you're actually hiding the keys and it becomes this hostile environment where the family member is blaming their loved one for taking the keys away, and it's a fight every day. Sometimes that can't be avoided, but there's other ways to go about it if somebody doesn't want to get rid of their keys. And then there's also these third-party evaluations. So it's an actual clinical driving evaluation, usually by like a physical or occupational therapist. They have these things, that these checklists that go through with the, typically it's like an elderly person who is doing these driving safety assessments. It's not only assessing for cognition, but also motor abilities to actually be able to drive the car. Henry Ford, Wyandotte has in their physical rehab department, they have an assessment that they can do. And some other hospitals have systems have those as well. So then it's not the loved one taking the keys away, it's, the doctor or the hospital or whatever it may be. So this is that handout that I brought. This is not an area of expertise that I have at all. So I just printed out a handout if anybody does want any more information on this. I have seen it happen many times before even there was really, not exactly before there was internet, but before there was internet the way it is, where it's on your phone at all times, or, it's just like, we're not really living in a world without internet. Back 15 years ago, it was a little bit different, where it was a little bit harder to get on and whatnot. But I've even seen, so back when I was in Chicago, we used to do all of our scheduling, call our participants and do it all set up. And this one participant was impossible to get a hold of. She stopped answering her phone. She wasn't really leaving her apartment very much because all her money that she had, her life savings, was disappearing because she got involved in one of these scams. So she became very isolated because of that. So, there's different, this handout kind of goes through these different sorts of scams and fraud, and whatnot that the elderly population is more susceptible to. When somebody has dementia and they're less discerning and they're not able to, use their executive functioning skills to make good decisions, they certainly can become more of a target. So on this handout, there's some phone numbers, there's some tips on how to prevent some of these things. One of my coworkers called me this week. Her mom lives with her and she's like, what am I supposed to do? She's giving out her bank information and now she just got like $100 stolen. And this is a woman who only has $5,000 to her name, so she's like, do I need to take full control of all her bank accounts? I'm like, yes, you do. Like, this is that she's not going, you can't explain to this. This is the second time it's happened. And she worked like this, my coworker, she works in healthcare. She knows, she's seen dementia progress, but with her own family member, she was having trouble being like, is this real? Like, she's like, I told her, like, this happened before, you can't do it again. And I'm like, but you also told me that, she can't remember what she had for breakfast. So she's not going to remember this conversation that you had her. She's not able to manage her money anymore. So yes, you need to take control of all her bank accounts and she can't access those anymore. Yeah, obviously not carrying around a social security card. Most people aren't doing that anymore. I've seen a few people still do that in their wallet, carrying a social security card. I would try to avoid that. Right, exactly. That's the thing, carrying them. Yes. Yeah. It was easy if everybody's a good person, but not working now. Yeah. people are becoming with cell phones and whatnot. Yeah. So the reason why I have this one on here, especially for a home caregiver, is because when you're caring for somebody with dementia, you do expect to see changes in cognition. That's what you're being told. This disease is going to progress. We expect a gradual progression. What we don't expect is they're acting like their normal self one day, and within 2-3 days, all of a sudden, they are more confused, more tired, more irritable, hallucinations, delusions, all that kind of out of nowhere in a short period of time. That may be what we call delirium. So delirium is not a dementia. This is a fast change that can be caused by different things that need to be treated, usually clinically. Well, that's yes, and that one can be yes. So you're used to seeing some changes one day, another day, another. Yes, I agree with Lewy bodies that can certainly, that sort of quick change be a disease rather than the delirium, certainly. But also somebody with dementia, even somebody with Lewy body, they can also experience delirium. You know, if there is an infection going on, or if there is dehydration, different things can cause that. So that's why I always add that and educate on that, because urinary tract infections are very common in the elderly population. That's probably one of the most common infections that causes a delirium, more common in women than men, but it can occur in men, where people will start to see these behavior changes and they get treated for their urinary tract infection and can see quite an improvement. And then this one, this is more of a safety concern for the caregiver, but can also be a safety concern for the person with dementia. So what we call is behavioral symptoms well, technically behavioral and psychological symptoms in dementia. Very, very common, especially in some of the more behavioral types of dementia, Lewy body dementia, certainly, frontal temporal dementia. You're going to see some of these behaviors may be stronger or more often, but I see these behaviors in Alzheimer's disease all the time as well. So, and usually more than one. Restlessness, wandering, pacing, anxiety, depression, agitation, irritability, apathy, so just not wanting to do any of the normal things that you used to want to do. Sleep changes, either a lot more sleep or a lot less sleep, or their day and nights get affected and switched, appetite changes, etc. So these common behaviors, there's not always an easy solution for them. And it's about adapting the environment, adapting your approach as a caregiver, and then also realizing that what you're doing today might not work in a month, or whatnot, depending on the disease progression and the issues that arise at that time. But one thing that can be difficult is the amount of caregiver stress. So once these behavioral symptoms start, it really ticks up the amount of caregiver stress, because these are not easy behaviors. Even the constant wandering or restlessness, or having to feel like they need to be, they're active or engaged in activity at all times or whatnot, or they forgot that they just ate breakfast and they just had breakfast 5 minutes ago, so they're asking again. These are behaviors, and while maybe that's not a safety concern in the moment, it does weigh on a caregiver throughout that. So know that while it's common and it happens, I understand that it can still be very difficult for a caregiver. When it does become more of a safety concern, so when we start seeing aggressiveness or combativeness directed toward themselves or a caregiver. So the hitting, the kicking, the threatening, the throwing objects, these, it's very common. And I've had people, loved ones, spouses, children, who have had to lock themselves in a room, call 911 and have somebody come because there was no redirect. And that's what, at that point, you have to remember, well, you would never ever want to call 911 on your loved one. You don't want them to go to the hospital to be treated for these behaviors. You also are their only, a lot of these situations, you're the only caregiver. Something happens to you, then you're out, and then your loved one is also has no caregiver. So you do have to think about your own self and your own safety. And if something, if you're in a dangerous situation, okay to call 911. So some of, if you see an uptick in those sort of aggressive combative behaviors, talk about it with your provider. What can we do to sort of maybe take the edge off some of these behaviors? So using medication is not a first line intervention. There are different ways to redirect somebody, to keep the environment, simplify the environment. Sometimes it's just too stimulating. So this irritability and agitation picks up because of that. A common trigger can be feeling uncomfortable. So they have to go to the bathroom. They're in chronic pain. They're not sleeping. There's multiple things that would make somebody with normal cognition feel irritable, but we're able to sort of manage those emotions better. That's the kind of stuff. So once you've ensured that all the basic needs are met, they're not in pain, the environment is at an appropriate level of stimulation. There may be times and phases as the disease progresses where you need to get some clinical interventions, where you need to ask your doctor for some medication assistance. Then when we get to like hallucinations and delusions and paranoia, that's also very common in all the different types of dementias as they progress. What I tell caregivers, if the hallucination and the delusion is a happy hallucination or a neutral delusion, if they think that their mom is with them and they're having a great time, leave it. Be there with them, not an issue. There's no need to correct those hallucinations or delusions as long as they're not upsetting. The only time it becomes upsetting, where you might want to seek out some medical treatment, medication, whatnot, is if people are having distressing hallucinations where, I've heard people say there's spiders crawling all over, or there's like mice all over the floor, or they're not able to sleep because they're certain that somebody is trying to come in, break into their house and hurt them. There are those sort of behaviors that really impact quality of life. And sometimes there are certain medications that can take the edge off of that as well. And it's like I tell loved ones who don't want to start these antipsychotic medications or other psychological medications. It's like with chronic pain. You don't want to go to a strong pain medication, but also you wouldn't want your loved one to live a life of chronic pain. So trying to find a balance between side effects of medication, treating some of those symptoms, also with obviously, like pain medication does have side effects, but living in chronic pain also has side effects. This is constant anxiety and irritability and fear that impacts somebody's quality of life. Now, are there side effects and reasons not to take the antipsychotic medication? Yes, there are that too. But a doctor can help you outweigh the pros and cons of treating these behaviors with medications. So, I kind of already went through this a little bit, but identifying the triggers is a big thing. What kind of instigates these behaviors? Sometimes it's easy to tell, and sometimes it just comes out of nowhere. But it can be helpful to keep, if these behaviors start increasing, to keep a log of it, kind of a diary of the day. So even when you do bring this to talk to your physician about this, to be able to say, to kind of track what's causing it, what time of the day is causing it. Okay, this may be when the blood sugar drops, who knows? There can be certain things that trigger that. If you keep a log of it and are able to look back, it's easier to identify. Because when you're in the midst of it, in that caregiver role, the day-to-day, they all become a blur and it's stressful. There's a lot going on. So kind of forcing yourself to log things can be very helpful. Redirecting, calm environment, even addressing boredom. So sometimes just giving somebody to do it, it can be very simple, not something complex. A task that it may not be a meaningful task, it may be sorting out, like if you buy a bunch of beads and it's like, okay, I want you to sort out all the blue beads. Something that, you know, doesn't seem like it would be fun, but it gives somebody something to do. It actually does stimulate their brain. They are using a bit of that higher level thinking. And for the moment, it may kind of decrease their risk for becoming irritable or agitated and bored. So, and I said those basic physiological needs: hunger, thirst, pain, bathroom needs. Things that you might not think of. A tag on a t-shirt that you might cut off on your own shirt because you're like, that's been bothering me all day. Okay, somebody with dementia may have that same feeling, but they're not able to tell you that. They're uncomfortable, but they're not able to verbalize why they're uncomfortable. I've had a patient who, he was a dentist, very educated, very smart man, probably in the moderate phases of dementia. He walked over and he's like, something's wrong, but I don't know what's wrong. Something just doesn't feel right. And he looked down at his feet and he had his shoes on the wrong feet. Okay. The same pair, he was dressed perfectly fine, looked nice, but his shoes are on different feet. And he couldn't figure out what was wrong, but something was wrong. So even that's why I say it's little irritable things. They just, for whatever reason, they can't identify it or express. So it's like getting creative on why they're irritable today, you know. Back pain too. A mattress that's decades old that they kind of have this chronic back pain, and sometimes it's due to a mattress that isn't offering any support. Not able to identify that, irritable all day. Untreated pain can certainly be a source of irritability in people with dementia. Yeah, so then again, just kind of reiterate, if life feels in danger, calling 911 is better than the alternative. And then finally, this is kind of my last slide here, is levels of care considerations. So a lot of people want advice on, can I leave my loved one alone? And that's a hard question to answer when you're not with that loved one every day, seeing how they navigate the world and their surroundings and whatnot. But, you know, typically people will slowly decrease the amount of time that they're left alone. So, you know, initially maybe like for an overnight, fine, no problems. They know they are able to use their cell phone, they're able to know, you know, that's fine. That's not a problem in the beginning stages of the disease for most people. As it progresses, you know, that an overnight would be too much, and even it can get to even being left alone for an hour, you know, can become too much. So then it's one caregiver able to adequately meet the needs of my loved one now and as their disease progresses. Of course, there's alternative options of care: assisted living, private duty caregiver coming to the home, rotating family members, an adult daycare, those sort of things. All those sort of things, apart from the rotating family members, also cost money. They're not always an option. That's the most difficult thing when there isn't another option other than that one caregiver. So that's when there are other support. I mean, I don't know, you guys have some experience in this, I know, but you know, it's reaching out, trying, if support systems are good for the caregiver. There are community things available. It's not great. There's not a ton of options once you get to that final stage, but that's why, you know, I would say, knowing that this is a disease that progresses, as long as, like, the earlier you can start with some sort of planning, problem solving, getting people, whether it's friends, family, or whatnot, on board to provide some support for the caregiver as well, is certainly helpful. And then these are just for anybody, the alls.org, their help and support, they have so much information and so many good ideas, and also other local chapters if there's more assistance needed. The Dementia National Institute on Aging is very helpful, and then our own website has information that our wellness initiative, and then the education and outreach team. So certainly reach out to that resource as well. So that's all I have in terms of my slides, but can answer any questions or discussion, or if anybody has any other things to add relevant to the topic. Mhm.
Hydration or hydration. Dehydration, but neuron. Strong. They're losing neuron connectivity and neuron already. Have some more fried.
Yeah. Yeah, and dehydration is very common in this population. They're not remembering to drink. They may be thirsty, but they don't know that drinking a glass of water is going to improve their thirst. So as a caregiver, it's always like, leave the cup of water by them. A straw. Using a straw tends to cause people to drink more for whatever reason. So keeping a full glass of water, something that they like to drink. Somebody hates water. I want water. I will take water before any other drink. That's my go-to. But some people, they just really won't drink water. Okay, so try to avoid something sugary or something that's going to be more dehydrating, like coffee or caffeinated tea or whatnot. Not that you can't have coffee, but like I say, if you're going to have a cup of coffee, you need to balance it with 2 cups of water, because a coffee and a water is like neutral. So if you want to actually hydrate, then you're going to have to add another glass of water or something. Flavor it with something, a little squirt of lemon or a Crystal Light or whatever it may be. So, yes.
December of 2006.
Okay.
She's been caught. And all of a sudden, forgot about love doesn't make it any fun. 8 months later, dehydration, I wasn't aware of it. Oh, she got some water.
Something, yeah.
8 months later, off to go to the hospital. That's 5 days. That was her, one of her.
Yeah.
Staring at.
Well, yeah, and so I mean, like so a non-caffeinated coffee is going to be is going to take out less water than also different strengths of coffee. So caffeine in general is a diuretic, which means it actually takes water out of cells. But yes, I mean it's still, there's still a lot of water in it, but it can be better than nothing if she went from coffee to nothing. Yeah.
It's not noticeable if you're not looking.
Yeah. Right. And that's what I think that's a good example to remember, things that seem so basic to us, like, okay, if I'm hungry, I'm going to eat. If I'm thirsty, I'm going to drink. Somebody, as the dementia advances, they may feel that pit of hunger in their stomach, but not be able to connect the dots, like, oh, I have a stomach ache because I'm hungry, or my mouth is dry because I'm thirsty. So just kind of remembering always to simplify things. And that's why I say, if you can really, that's why I tell caregivers and facilities as well. If you can focus on those basic needs, you're going to solve a lot of problems before they become bigger problems, by just ensuring that everybody's really basic needs are being met. Mm-hmm.
My mother one time went to the washing machine pretty deep, beyond the station.
Mm-hmm.
And she kept turning the back. It's a habit. We still can do our habits.
Mm-hmm.
I close my eyes and walk through her.
Yeah.
Well, it's not their fault. Living a habit that's like baking with thought and purpose. And for the oven. Even really, you can't check it with the unknowingly, it's easy to get hurt.
Yeah. Well, yeah, I mean, it's like when you have, you know, small children too, and they do something that's so irrational, but they don't know better. And if safety is a concern, you know, and for a, you know, a caregiver was to mention, well, when you're worried about like either the safety of your home or your loved one or whatnot, yes, it's easy to overreact in the situation. But that's what, you know, if you can prevent these things and adapt the environment to be more secure and safe and try to decrease the likelihood of something like that happening. But can't think of everything.
Guys, been on your page about, I think,
Mhm.
I know you had something down in Wine Gap. Two of them uses A&A driving school in Livonia. They report them.
Okay.
And they specialize in keeping people on the road if they can. Making sure
Yeah.
that communications be made in that far away.
Sure, yeah, that makes sense.
Because
Well, and that's why it's nice to do those clinical evaluations like that, and like the one there.
they did computer evaluation. For that.
Right. You know, as a trained like occupational therapist, that's exactly what they're trained to do, is adapt the environment to make somebody as independent as possible despite their limitations. So in terms of, yeah, driving as well, but then if there are some things that are an obvious no, then we get to that point then eventually. Yeah, that's that and showering are like two of the conversations I feel like I have the most of how to get somebody who doesn't want to shower to shower. That's a whole topic just on that, where we could have a 45-minute presentation and discussion, I'm sure. And it's hard because it's so individualized and everybody needs a different approach, and tips and tricks for each person is different for the next person. And I don't know, that's a tough one. Yeah.
You have any other questions?
Enjoy lunch. I did home safety. So if anybody wants, I didn't print out. I printed out. They're right on the back here.
It's just a